Our esteemed council.
Okay, call the meeting to order. Is that, can you guys hear me? Yes, okay. Welcome, State Board of Pharmacy meeting, day 2. I'll do roll call. Alan, do you want, or Greg, do you want to start us out?
Greg Lippy, public member.
Alan Shad, licensee member.
Ryan Brooks, public member.
Stan Weiser, licensed member.
Licensee member.
Yeah, and I'm also with the DMV, I might add.
With the DMV?
Department of Motor Vehicles, I got a license with them as well.
We
We don't really want to know about all your licenses.
Valerie Munoz, public member.
Victor Law, licensee member.
Amy Gutierrez, licensee member.
Debbie Veal, am I on? Debbie Veal, licensee member.
Are these on?
Albert Wall, professional member.
Okay, before we get the meeting going on the agenda, we have a couple of announcements. Found my portable phone, microphone here. Is this on? Okay. Ginny, you want to come up with me?
Few things would give me greater pleasure.
So Ginny and I have the honor of acknowledging 2 of the board staff that have achieved 25 years of service. So Susan Capello, where are you? Now, I have the honor of working with Susan quite a bit as I've been president, and she is amazing. She runs our enforcement area and always is available. I even get emails from her on weekends. So she is very, very hardworking, a very pleasure to work with. Susan, congratulations for 25 years with the Board of Pharmacy. Congratulations.
Thank you.
All right, and it's my privilege to recognize one of our employees that's actually had 35 years of state service. And the person's just now didn't know that this was going to happen to him, and he's now getting ready to do an appearance in the front of the room. Joey, would you please come up? This is Mr. Joey Patman. First of all, 35 years. Congratulations. Turn around and let's get you on the camera. This face should look familiar. He is the face of the Board of Pharmacy on our website. Now, we have a Senate proclamation. 25 years is what the state typically acknowledges as a lengthy service with the state. For many of us, how we ever made 25 years is an amazing feat, too, to note. But in this particular case, at 35 years, they don't really acknowledge you. So his manager, who's Rob Buckner, went out of his way to get a state senator do a proclamation for Mr. Patman. This is your proclamation. It's signed by Senator Nielsen. Both yours and Susan should have been framed by the board, and I apologize that didn't occur. Now, I have 2 pages worth of commendations. I think I need to read it in the record. 35 years, Joey, all those mornings getting up. And I know your best job is the one you've got now, but I think we need to do this. So, whereas a native of the Philippines, Jose G. Patman, is it Patman? Patman. Yes. If I'm going to repeat it on every paragraph, and that's what I'm going to do, I want to pronounce it. I think, well, let me hand you the microphone then. 35 years, you have come in as an immigrant, you've become a citizen, you have worked your way through college and through the state system. We are grateful you're with us. We're delighted to have you as the face of the Board of Pharmacy on our website. You are just a pleasure to work with, and he is a charming person. I walk by him, and he constantly acknowledges people as they walk by, which is kind of a nice trait, too. So I'm going to give you the microphone. You can say whatever you wish, but on behalf of the board, thank you very much for your 35 years of service. It is a pleasure to have you with us.
really get put on the spot, and I will try to say this in the English language because English is my third language. Yes, ma'am, it is. So it is indeed an honor and a privilege to have served that long. It seemed like not so long ago in 1982. I started with the state senate, spent 4 years over there, went to DMV, spent a few years over there, almost 30 years, and I'm here now. And so it's been a great adventure, and I thank you all for the kindness and consideration.
Thank you very much for your service. Thank you. It was not meant to embarrass you. It is seriously to have a good time, but to acknowledge a real serious commitment to the board. So thank you very much. Yes. You want arms around each other? I'm afraid to just kind of go. This is a different world.
One with and one without.
All right.
Another one? Okay, yeah.
This guy also plays guitar in a band, and he was our Christmas
Wow. Very talented.
music so much.
Congratulations.
I knew you were going to take it away from me.
Okay, we will get back on to the agenda. So now we have Communication and Public Education Committee, and Board Member Veal is going to give us a report. Debbie?
Thank you. So we had our public communication, public education meeting last week on January 31st. And first off, we had a presentation by a former board member, Ramon Casablanc, regarding prescription drug overdose prevention and corresponding responsibility, something that has been near and dear to his heart. And when he was on the board, he actually chaired a subcommittee. And the presentation just went over the opioid overdoses and effectiveness of naloxone and reversing overdoses. One of his main points was our board website did not have a link that he thought was as usable as he's seen on other websites. So he specifically presented us with an example for the Kentucky board, which our public information officer, I think, appreciated and will be using that to see if there's something we can't do with our own website in the future. He also said that he has given multiple presentations to pharmacists in California, and that he had found that there's some confusion among the pharmacists about corresponding responsibility, how to use cures. My only excuse is I've already had a lot of sugar this morning. I had a part of a cookie, I had a donut, so my sugar overdose might be affecting me here. And also about how to calculate the morphine equivalent. So he was hoping that that's additional information we could provide, and also perhaps through CE that we could communicate that to the pharmacist. But he just felt like a lot of education was needed to reach out to the pharmacists in the state of California about the opioid epidemic. He did have a short presentation, which, if you'd like to review it, is on attachment 1. And so then afterwards, the committee just discussed some of his comments, specifically around training on naloxone and corresponding responsibility. And our executive officer noted that in the presentations that we've had recently, that we've attached naloxone training, and that's enabled us to, specifically the Board of Pharmacy, reach out and train 700 pharmacists recently. As we've been giving our DEA presentations. And in a minute, in my report, I'm also going to talk about where we would also are going to be proposing to the board that we have a CE webinar for naloxone training on the board website. So, wait, that's to come within the next half hour. And so really our focus was on, what can we do to help educate the pharmacists about naloxone and red flags. We asked the staff if they could work on ways to make those topics more visible on the website. And I know, Bob, you are very committed to it. And potentially, right from the homepage, like what Kentucky did is right when you landed on their homepage, one of the most prominent buttons that you saw was going to opioid information. So I think that that's the direction that we gave the board staff. Is there any comments or thoughts or questions from the board members?
Well, actually, since he left the board, we have had a few more DEA and these corresponding responsibility classes. After that, we had the meeting at KGI, we had meeting at North State, and recently that we just had one in San Francisco. So more than like at least 200 pharmacists attend at this event. So I would say that not all pharmacists are not educated and unaware. Actually, most of them they do. In fact, I think that more of these classes are still in planning. Is that correct, Jenny?
We were asked by a reporter how many people have been trained through our webinar or through our presentations on naloxone, and we are pretty close to 700 people. Most people that come stay for that, and so we're going to use the count as 700, and we are now looking at doing another one. It looks like April 29th. I think it's a Saturday in Los Angeles. And we're trying to set that up. We will announce it through our subscriber alert, and they're very well attended. Because they're free, we get a lot of registration, and sometimes we don't have everybody attend. So we may end up starting to overbook a little further so that we can really make sure we fill the room.
That's the observation I have, and some of my staff would like to register, and they say it's all full. I attend the one at UCSF have briefly, and a lot of empty seat, and
About a third of the people didn't.
yeah, and Mr. Lennox told me that in the future, I think we should take a few more registration, because there's a lot of no-show, so we should take advantage of it, because I understand about 150 of them are on the waiting list. Yeah.
We had a lot on the waiting list.
Yeah.
We had out of 300 pre-enrolled.
Yeah.
300 pre-enrolled. We had about 220 show up, so maybe it was about 75%. But again, it has happened at all of them. Part of that's the nature of offering free CE. It's a little less investment in attending.
So my point is that to all the licensee, we increase your fee, and we give it back to you on the free CE. So take advantage of it. And I hope don't get mad at us for increasing your fee. And also, I'd like to see it to have this seminar at different locations that they all have a chance to attend. And I think it's very important we have that.
I mean, Jenny, that was like about the fourth or fifth. I mean, you've had quite a few, haven't you?
Yeah, we're trying to do them at least once a quarter. So I think that was the fourth one maybe since July. So we're trying to do them because it's hot right now. Everything is prescription drug abuse. So we need to be out there educating our population. So
Is it necessary that,
Oh, is your mic on?
what's that, my mic on? Oh.
I don't know. There's a lot of tape on it.
Okay.
Maybe I can get a little shock here if I keep squeezing.
Some of the CEs that I've taken in the past have been webinar programs that are, you have to watch the whole thing and then you take a test on it, et cetera. Could the board do something like that? I mean, that would increase access at all times for.
So two things. If you wait about 30 minutes, I'm going to talk about a CE that we are going to propose.
Well, if you would hurry up, we could be there now, and I wouldn't have to waste.
Oh my.
Can we do
Leave now?
Can we do the same thing on the ethic courses seminar for that?
For what?
Ethics.
Yeah, that one we need to develop some questions and some topical material on doing that, and I'm going to work with a
that
couple of
probably-
the
that
schools
probably
to
good.
do that.
And Albert, that's in about 45 minutes. We're going to talk about that.
Maybe an hour.
Maybe an hour now. Any comments from the public? Okay, I'm going to move on to agenda item number 2, excuse me, B. Discussion and consideration of a proposal for public service billboard message and related communication material on drug abuse. So if you've attended our board meetings, whether it be the full board or the Communication and Public Education Committee, you know that we have had a billboard, actually 5 billboards given to the board to advertise, discuss, bring up the topic of drug abuse by member Brooks's firm, Outfront Media. It's taken a while to figure out, the message we want, exactly what we wanted to say, but we are now there. So the board at our last meeting delegated to our chairperson, Mr. Sanchez, and our executive officer, Ms. Harold, to fine-tune, figure out the exact billboard, and present the winning display to the board. Do you have it up? Okay.
Is that the winning display?
That is the winning display. So this, so right now, I think, Bob, and I'll let you speak in a minute, you're working with Outfront Media to kind of finalize exactly, fine-tune the billboard, and then move forward with having it put up. Is there anything you would like to add?
Thank you, Ms. Veal. I just want to say that we are working with Outfront. Our designer, Victor Perez, who designed this billboard, is in touch with them, has been in touch with them to give them the specifications they need to get rolling on this. And I've been in touch with Tim Fox, who's been very helpful for through this whole process. So we're looking to move forward with this right away. Simultaneously, we're developing our new web page for prescription drug abuse programs and take-back collection bins for the public, so that when they see these billboards, if you'll notice at the bottom of the billboard, it says, for more information, visit www.pharmacy.ca.gov. So when they come to our web page, they'll see this sign again, they'll click on it, and that'll take them to our web page on prescription drug abuse programs and where to find take-back collection bins. So we're hoping to roll this all out simultaneously so that we're up and ready to go when the billboards first go up.
Yeah, and let me just kind of re-highlight what Bob said is, in my first report, we were talking about having a button that was prominent on the web page when you go to the California Board of Pharmacy. And so what we're planning on doing is using this billboard when you go to the website. That'll be the picture that you'll see, that you'll press to kind of go into these resources, because we want to make it not only a great place for pharmacists and all of our licensees, but also the general public. So if they truly are driving down the freeway, that kind of makes me a little bit nervous that they're going to be driving down the freeway and writing down our website. But if they figure out, maybe they snap it or whatever. If they get to our webpage, yeah.
That'll be better, yeah.
But anyway, hopefully they get to our webpage and they will see this billboard they'll recognize them. And one of the things that we're going to probably talk a little bit again later about is trying to have a central repository, because this is driving people to also, know how to get rid of their medications. So we're going to have, like Bob just said, we're going to have a central repository where you can go look and you can find, various options throughout the state of where you can get rid of your medication, not just places that are registered at the Board of Pharmacy, but, police stations and other sites such as that. And we're also hoping that from this button is also where this resource for education is, whether it be pharmacist education or the public's education. Is there any other comments from the board members? And remember, Alan and Albert, we're going to be talking about the CE webinars in a minute, okay?
Debbie, I had a question. So we're saying we're referring them to our website. When they get there, in terms, is it easily able to find how to resolve this?
Right. So you'll see a picture of this billboard. It'll be the button. So you get to our website.
On the website.
On the website.
Okay.
So you'll push on that,
Perfect.
and then from that we will be driven to
Right. Thank you.
Source.
Was there a reason we didn't put the website in large letters on the top so people could easily see it?
Because our message is drug abuse, and so that was kind of the primary message, and the secondary message was the source, a resource.
Because nobody's really going to see that. I mean, If
And
you're driving, you're not going to see that website reference. That's all I'm saying.
but this is the first time ever that I have seen any propaganda from the Pharmacy Board of California. So I think we should go ahead, move on, and make this conspicuous to everyone. And also, we couldn't have done it without the generosity of Mr. Ryan Brooks. I think we owe him one.
And I think, Greg, kind of to your point, it's not just billboards, it's kind of a whole campaign.
I know, I just thought that.
I don't think you're talking in the microphones if you want to be.
I know, I just thought that if I was driving down the freeway or somewhere and saw a billboard, and I saw on the top, www.pharmacy.ca.gov, then below it, in similar sized letters like that, everything else, that would cause me to go to the website. But if I'm reading that and I'm trying to figure out what it says below, I'm already into the car in front of me. So I'm not going to look at it.
Well, I kind of go from top to bottom, so I know I actually see a message and I write the phone number from the bottom, but.
The main message is not the board of pharmacy. The main message is try to convey.
And it's one of those things too in Los Angeles. Generally, you're not traveling at 80 miles an hour on the freeway. You're going to have a little bit of time to take a look and really decipher it. As Debbie says, pick up that cell phone and take the picture anyway. We're also doing 2 in Sacramento and 1 in Fresno where we can have traffic every bit as bad as LA now. So the people that are just coming from South Carolina, driving from Los Angeles to San Francisco that see the billboard may not benefit from it, but the ones that see it every day, it's the repeat message. Maybe on the 3rd or 4th hit, if they're really interested, they'll get the web address. And the web address is actually pretty easy once they get, okay, it's pharmacy.ca.gov. I mean, it's really straightforward. We're lucky that we have that. But the message, as Mr. Brooks just said, is really what we were pushing, not promotion of the Board of Pharmacy per se.
And if you've remembered, we've looked at probably 10 of these, and we've always had like, you've seen all the other renditions we've had. And the other renditions had like a little Board of Pharmacy down at the bottom. This time we decided, if we're going to have the Board of Pharmacy, let's go ahead and put the website too. So
idea.
It's the message, not the Board of Pharmacy.
Well, the important thing is to get the message out. So let's see how it works. We'll get feedback, I'm sure.
Any comment from the public? Seeing none, I'm going to move on to agenda item C, discussion and consideration of possible options for consumer and pharmacist education regarding safe medication. In the July 2017 board meeting, the board directed the committee to discuss developing materials to educate consumers and pharmacists around the importance of having patient medication history on hand. So the first thing we thought about is, let's have an app. And we were sitting in a committee meeting one day and realized, gosh, we probably all have an app already on our phone where you could, put down all of your medication and your history. So probably having the board and poor Bob try to figure out how to create an app was not the most efficient way to move forward. It was probably more getting the message out to the consumers about, and really the pharmacists to encourage consumers is about, there are apps on your phone. You should use them. If you're not an app kind of person, that we actually have like little medication cards you can get off the board website or from various vendors. But just how important it is to have your medication information stored somewhere so in an emergency people can get it. So the committee received, and then in addition, or more recently, the committee had received some information from Rita Shane from Cedars-Sinai, and I think that is in attachment 3, as well as an article from U.S. News and World Report, 9 Strategies for Reducing Emergency Medication Errors. That's also in attachment 3. So that's some very good resources. Rita's point was about when you are admitted to a hospital, how important it is to have that list of medication. And then also she goes into when you're discharged from the hospital to understand, what's happening. Has this medication been discontinued? And so you need to make sure that your healthcare providers know about that. So we discussed ways to convey the information about safe medication transitions to the consumers and pharmacists. The committee directed the staff to explore ways to inform the consumers about compelling an array of current medication inventory through various media, including the board's website and DCA's blog, publications, and social media accounts. We're also going to put an article in the script, I think, in the near future about the role of pharmacists in reducing medication errors. We're going to highlight or point to potentially both the article and Ms. Shane's presentation. And we also are going to reach out to the pharmacy schools to see if they could include in their curriculum information about safe medication transition. We had a pharmacist who was actually very interesting who has a pharmacy in Oakland who came up and spoke about how his specific pharmacy was handling transitions with the Alameda healthcare system. Bob, I don't know if there's anything else you want to add as far as the outreach that you're planning?
No, ma'am, I think you pretty much covered it all. We will be working on these materials for two distinct audiences, one for licensees, articles in the script that we can share with the other healing arts boards, and others materials targeted more toward consumers. And we can get those out through more consumer-oriented media, such as the DCA blog, other materials that more consumers are more likely to go to.
Thank you. Are there any other comments from the board or Jenny?
As a last resort, okay. I just think that this is such an important consumer topic that a number of individuals don't know anything about. I think that we need to kind of explore some consumer materials in this area and some consumer education. So I think we'll work a little bit with the department. They have some blogs and things that we don't operate independently, and we can maybe use some of that to just start building the message that these medication lists are real important. And if you don't have an accurate list, you're potentially looking at real trouble.
I think there's some good collaboration with CHA, because this is a hospital issue primarily in terms of admissions and discharges.
That's one of the greatest places where there's a friction point, but I think it's probably a problem, period.
I mean, just from an education standpoint,
I agree.
So that maybe we can do an article in it, in the news, in our script.
Well, we did. We've
Okay.
done already, and I think we've got another one coming. I don't know if there's one in the next newsletter, but we already did do one.
Okay. I know I mentioned it.
One of our infographics that Rita likes to do. So,
Okay.
But it's a real serious issue, and no one's aware of it. And so this is going to put us out front on something because of Dr. Shane that we really need to be involved in. So.
Well, I mean, and kind of just even getting back to the basics. I mean, just have it in your phone or, a piece of paper on your refrigerator that can be grabbed in case of an emergency. But did you get the organization that Amy just referenced?
CHA.
Yeah,
Yes.
okay. Is there any other board comment? Any public comment? Okay, seeing none, I'm going to move on to agenda item D, which is educational material regarding the drug take-back. At the July 2017 board meeting, the board directed the committee to develop consumer information around drug take-back programs. In the September 2017 committee meeting, the staff reported that online forms were being developed because as part of the drug take-back program, pharmacies do have to register their take-back receptacle with the board. So during our meeting, the staff reported and showed us the forms that can be used both with if you're installing or discontinuing a collection receptacle and how you would report if you've had any tampering, damage, or theft of the receptacle. And those items are all now posted on the board's website. And as a kind of a reminder, one of the requirements of being part of a drug take-back program is that you have to have a license and clear standing. So if, one of the things that we do is as these documents come in, if you don't kind of meet the qualifications to have a drug take-back program in your facility, then the board will notify you.
Yes.
An announcement about the forms.
Can I make a comment on the drug take back?
Can you wait just to the end of this? So one of the other things is we did send out through subscriber alert the information that the forms are on the website and how to access them. And if you'd like to see the forms, they're on attachment 4 in our packet. The staff also informed the committee that the forms have been used, will be used also through the tool that Bob's developing, so that we can inform you of where you can take your medications that you want to return. We also asked the staff, if they could tell us how many forms have been submitted. And I don't think we had a number.
We have that information now.
Okay.
Today, we've received about 160 forms for registering collection bins from pharmacists, and we've actually received already 6 notices of pharmacies who want to discontinue their collection bins.
That want to discontinue?
Yes,
Okay.
yes. So, but we are going to be able to have this set up so that pharmacists can just go online and fill out these forms and send them in online. And once they do, that'll automatically plug them into our registry of collection sites so that consumers can see where they are located.
Was that 160 forms or 160 locations?
160 registration applications we've received.
Okay, and they can only do one on the application at a time, I think, because early on I got lists where there'd be like 15, 20 locations that a single entity would create, and they were doing it that way initially, so.
Yeah, to be honest, I don't know if this number includes that count. This
Okay.
is just what we had from the forms.
Okay.
Debbie, is this the actual bins or if they have envelopes too?
This is the actual bins.
Okay.
Yeah, and so once again, Bob's creating this site. We had some of the public at our meeting, at our our committee meeting, who were also going to be willing and working with Bob to, add to our site. So it wouldn't only be pharmacies where there's receptacles, but other locations where there could be a take back. You're pointing to the screen? Okay. Okay. Thank you. And so are there the various websites where you can do the take back? And so what we're actually going to try to do, is that our website or, okay. So we're going to try to take, yay.
That's great.
So why don't you speak to that?
Thanks. This is a website that Victor Perez, our website master, has been working on. It's still in the alpha beta stage, beta testing, so it's not complete yet. But when you come to our website and because you're drawn there by our billboard or some other reason, and you click on it, it'll take you to a page that asks, what do you want to do? Do you want information about drug abuse, or do you want information about where to take back your medications? And if you click on that, it'll take you to this web page. And you'll see there that we have some explanatory information up there, a little bit about the types of drug take-back services pharmacies offer, whether it's collection bins or mail-back services. And if you want to find out if your particular pharmacy offers these, or if there's a pharmacy in your zip code or your city, you would just come down here and enter the name. This is still in the early testing stage, so we don't have a lot of data put in yet. But one of the guys who's developing this did type in his name as a sort of a pharmacist. So if his pharmacy was called Vaughn's Pharmacy, or that was your pharmacy, and you wanted to see if Vaughn's offers website or collection bins, you would just click on it, and it would show you 3 results of pharmacies of Vaughan pharmacies in your area that offer this service. And you notice we also on here indicate if the facility provides mail-back envelopes as well as collection bins. So this will just be another way for consumers to get information about their particular pharmacy, or if they don't know, if they just want to go to any pharmacy, they could type in, a zip code or city, but we're not quite set up for that yet. So this is a very early development stage, but it sort of gives you an idea of how this would work.
Looks great, thank you.
Yeah, that's great, because you kind of did that work since our committee meeting, so that's really good. And the other thing, I think right now it's linked to pharmacies, but our goal is that will be linked to the other sites also, correct?
I think that's the idea. We're starting with our pharmacies first because these are the forms we're getting in. And once we're able to get all of our licensees in this site, then we certainly want to include other collection bins or other collection sites as well, because I know there are a lot of other organizations and the DEA that have sites. And so if we could become one central repository for this information, I think that would be a really great benefit for consumers.
And because we are the Communication Public Education Committee, there will be an article in a future script edition about, take back and this whole topic. Are there any other comments? Albert, I know you had one.
Yeah, we have one in our pharmacy, and it's very well received in our community. And every time they come and pick it up, it's always full. So I'm very happy that we're doing this program. So it's working. And my next question is that we have this on medication take back. How about I have a problem with those used needle from the diabetic patient. They keep taking to me. They don't know where to dispose it. So I'm sure we're not the only one who have this problem. I think all pharmacies have the problem because most of the patients do not know where to take their needle, to use the needle. So I hope we could work something on that.
I can advise you only because we had this discussed in a meeting last week that in San Luis Obispo County, they've had a mandate for a long time to take back needles. They've now continued that, but they've also gotten pharmaceutical companies to provide some funding for it. So that's one county, one approach, but the needles are a real problem.
So, question, Debbie, on this, there's some counties that are funding it. So I'm suspecting, and Albert, is yours funded by the county, or do you fund it?
I think ours is the first one. Alameda, I'm in Alameda County,
Yeah.
so they're the one that make the drug company. I suppose so. I'm not paying for it.
So it'll be curious to see when you get this result, how many of them are in counties where there's funding provided.
Yeah.
Just
Yeah.
question.
Well, I'm glad that we did not have to force anybody to do this thing. I mean, I think that's a very high demand, but I'm sure there's a lot of pharmacy wanting to have one because it's good for the customer.
How many do you get, Albert, that comes in? A lot of them?
How many what?
How many patients that come in with drop-off?
Oh, I don't look at it. I mean, but it's full. But it's full. I mean, every time.
So maybe a better way to ask is how often do they have to come and empty it?
I think every 2 weeks or so.
That's pretty,
Yeah.
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 So on our website, do we have a link to how to dispose unused needles?
Not yet. Oh, not, yeah.
Well, we don't yet. That'll be information we'd like to include here. We also could include links to specific organizations like Cal Recycle that have locator functions on their website, and we'll link you directly to them, and you can type in your zip code and find places to take needles and sharps and other things that pharmacies might not take.
Okay.
We don't have a requirement that they register their collection bins for needles with us. But we do have one for, we want to know if they're doing mail back only so we can release the information. But for the collection bins, they do have to be registered with us as well. So, and definitely the same groups that work with us on the drug take back are very interested in working with us on the needles, which remains a big challenge. So we'll continue to work a little bit in the committee on this issue too.
Are there any comments from the public? Okay, seeing none, I'm going to move forward to agenda item E regarding, are you ready, Alan? The webinar for naloxone, okay? So SB 493 authorized boards to address the public of restricted public access to naloxone, which reverses opioid overdose. The board responded in 2015 with emergency regulation and a permanent regulation in 2017, which established a protocol to furnish naloxone without a prescription. And part of that protocol is some a training class. The board also took steps to assist pharmacists in taking advantage of naloxone protocols we mentioned earlier, through the attaching it to our DEA presentations, which we co-hosted with the DEA and provided 1 hour CE credit for the naloxone piece. And as we indicated earlier, about 700 people have taken advantage of the naloxone training in that combined meetings. So during this meeting, the staff requested the committee discuss and consider approval of a possible webinar course to satisfy 1 hours of CE to furnish naloxone. The course was developed by Talia Puzandian, PharmD of Keck Graduate School of Pharmacy, and James Gasper, PharmD, California Department of Healthcare Services. Attachment 5 is the webinar course, if you want to look it over. If you look at it, it's actually, we thought it was a very impressive course. It does a great job of presenting the overview of the opioid situation, kind of going through the medications, as you would expect, and how to identify an overdose, how to respond to an overdose, what to do once you've provided the medication. So it was a very thorough presentation. Dr. Gaspar then talked to us for a few moments and told us the course had been well received because he and Dr. Puzandian have presented the course mainly in Northern California, primarily in rural counties. Because if you were to go in the webinar, you would see that one of the biggest places where overdoses occur, the higher per capita, is in the more rural counties. And so that's where they have focused their efforts so far. And he said one of the most interesting things is just bringing together all the pharmacists at these meetings, because then they kind of are able to connect themselves, especially because it's a rural situation. It kind of built a little safety net just from the meetings that they were having. Our executive officer stated during our meeting that she thought the webinar was an important part of the naloxone material on the website, and that it would provide means for pharmacists to self-certify their participation and receive the 1 hour of CE credit. So what the committee recommendation is to move forward with creating potentially this very webinar course using the materials presented by Dr. Gaspar to satisfy the educational requirements for pharmacists to furnish naloxone. So obviously, this wouldn't be the only way, but we're just trying to make an additional avenue where someone could go ahead and get the CE. And kind of other discussions that we've had at the committee level, there have been comments that they feel like the pharmacists aren't offering naloxone to the the depth and breadth that it's available. So they want to make sure that as many pharmacists as possible are aware and are trained and can provide naloxone dispensing in the state. So this is just another way for us to kind of get out and make it easy for the pharmacists to be equipped to provide naloxone. Stan, did I see your hand?
Yeah. So did you say that 700 pharmacists have taken the class and eligibilized themselves for the naloxone program?
Through the DEA, Board of Pharmacy.
Yeah.
Yeah.
So out of the 40,000 licensed pharmacists that we have, we've only got 700.
No, only 700 got it that way.
From our CPHA is providing,
Got it,
we
got
know
it.
training, they can get it through pharmacist letter. So there are other sources they can use. What we're trying to do is the board charged the committee with a way to increase the number of pharmacists that are positioned to provide naloxone without a prescription. And this is part of how we're fulfilling that, is to help push it out there so that pharmacists really are one of the major entities for the dispensing of naloxone.
Yeah, we didn't want the lack of, like, the barrier to be, I can't take the CE course. So,
I can't find one
or I
or
can't
whatever.
find one. Some employers offer it and require it of their pharmacists. So there's certain employers that have, pretty much all their pharmacists trained. There's, like you said, through CPHA. So the meetings are one avenue. We're just trying to provide yet another avenue of how people can get trained to provide.
I think, the effort that we're putting forth is a good effort, and it hopefully will pay off. I don't know how many pharmacists we now have in the state that can, be part of the naloxone program. But to me, not to embrace this program, a professional, a pharmacist, not to embrace this program. And then the next topic you're going to have, and I won't preempt you in any way. But if the pharmacists, I mean, to me, it's just shocking that they don't embrace these programs, which bring them to, yet a higher level of professionalism as far as I'm concerned. So it's disappointing to me that it isn't much more popular than it is, but I'm glad to see that we are going in the right direction.
Well, and so one of the most interesting things is we've talked about this multiple times in this committee. We do need to make sure every pharmacist is educated and meets the protocol. But what has come through is the next step is that we have a lot of pharmacists that are educated and can meet the protocol. They can furnish the medication, but they're waiting for people to ask. Walk up to the counter and say, "I need naloxone." So that's the next barrier. I think the committee's kind of arrived at. Our next barrier is how do we, engage the pharmacist to say, this person is the first time they've been on opioid. Maybe I should bring it up. Or, they're taking high doses. Maybe I should bring it up. Their morphine equivalent is pretty high. Maybe I should talk to them about it instead of, waiting for the patient to realize any of those situations and say, can I get a naloxone? Now, Dr. Gaspar also said that there is a little bit of an issue where people are like, no, that's not me. I don't want it. But I think we do need to.
Isn't that what Mark was talking about yesterday, that CVS is rolling out? Because I was asking about it.
That was one thing he
Maybe
did.
maybe he could present at the Communication Public Ed and talk more about their program. Might be something that would be of interest.
Well, I've worked as technical assistance with a legislator that's interested in establishing a consultation requirement for opioids, and this would be one of the elements that they would discuss as part of the required training. So we may well see legislation this year that specifically requires pharmacists to provide a special consultation the first time they dispense an opioid, which puts us positioned exactly where we probably should be. And maybe it doesn't need to be a forever requirement that once they become more familiar with doing these kinds of consults.
But what about the prescriber counseling the patient when they first prescribe the opioid? Because that's where it starts. And there's a lot of data that will show, I've seen articles that show that if someone gets exposed to opioids in the ED, that's probably the biggest area, 6 months later, they're probably going to be more likely to have on chronic opioids. So attacking that prescriber right at the stage one when they start prescribing it.
We can bring them in.
I was going to say, actually, the other thing I've read, and this was about a year ago, is that once you tell the prescriber, if you write for opioids, you have to write for naloxone, that causes them to think twice about writing for the opioid.
That's a great point.
Can we have the Board of Pharmacy provide some poster, and then they could post on the pharmacy about, the website or the opioid problem. So we could educate the public by posting the poster in the retail pharmacy.
Yeah, we can look at a communication. We can look in our committee if that would be okay with you, Amy. But we could look and see if maybe we could develop something.
The other question I was going to ask you, Debbie, is when you started talking about the rural pharmacy, started thinking about this, these remote pharmacies, can a pharmacist participate in that remotely? Do we have the ability for a pharmacist to counsel a patient if they have video conferencing in these remote pharmacies?
That's a good
Or
question.
does it have to be in person?
It would be telepharmacy, and then the tech would hand out the naloxone. That's what would have to happen. I don't know if you have an opinion on that.
Could we do that with, and the only reason I ask is because of your comments about the rural locations, because if we have a remote pharmacy, they should have the ability to do that.
They do. There's a requirement.
So the pharmacist
They have to consult on
could the
video, not just the
pharmacist do this work, Jenny, via telepharmacy? So if there's a video screen, they can
And then
actually.
the tech would hand out.
They have to have a means by which they communicate with the patient before the drug can go to the patient.
Okay.
So we can.
Do we need to add that? We don't need to put that in the remote pharmacy?
I believe it's already in there. You guys keep asking.
It's
where do
in
you
the
think my-
exam.
I think she's saying, is it in the remote
licensing.
pharmacy reg that?
I think it's already in the statute. That was one of the discussion points last year when the bill was.
As licensed chair, what do you think? Is it a good idea?
What was the
So
discussion?
this is for the remote pharmacies. If
Right.
the pharmacist was able to counsel from wherever they're at, that's overseeing that pharmacy, could the technician then provide the naloxone?
I would have no problem with that at all as a professional. And so, I mean, the issue is admitting to the fact that there's a problem out there, and then getting people who are willing to step up and help with the problem and the availability in the naloxone. We're talking about saving a life here. And so, whoever it is, be it a fireman, an accountant, a pharmacy tech, or a pharmacist, you know, give it a shot and save a life. You know.
So perhaps what we could do, Jenny, is you could review the laws every day.
That's the bottom of the poster.
Yeah,
Give
now
a shot
I
and
think that
save
the
a life.
accountancy board ought to look
Yeah,
at this as well.
that's a good logo.
You know, maybe look at the law. If there's anything we need to do to modify a reg or anything, we can bring it back to the board. But I think what I'm hearing is the board strongly believes we should provide that option. Correct?
And so then maybe that's part of, as we, roll into rural pharmacies, that we make sure, because that was one of the things Dr. Gaspar he spoke to us a couple times, but the biggest problem is in the rural communities, because if you're in like downtown LA and you overdose, policemen, everyone has it, there's a bunch of people around, it's not as critical as if you're in the sticks. Yes, Mr. Brooks.
A quick question for you.
What's that?
Are schools and universities allowed to carry naloxone?
I think, I don't know, Laura, or
I don't know if they have any personnel. It seemed like the school nurse.
the school
is
nurse.
now gone from schools, and I don't know if there would be anybody.
I don't believe that most, at least in my districts that I'm familiar with, there are no health professionals on school campuses anymore.
I mean,
So I don't think there's anyone there, and they're not even able to give aspirin or anything. So I don't.
Right, but it doesn't have to be a health professional that gives it, because you hear about policemen and.
Right, but there's nobody like that. I mean, at least at the elementary school level. Maybe in high schools they have, cops on, but I don't think there's anyone really in most schools that's able to give naloxone.
My son goes to a really big school. It happens to be a private school. And there's the security guards and there's nurses and team trainers and whole 9 yards. Would they be able to qualify to carry naloxone on campus?
I would think so, because we can dispense it to anybody. we don't even have to have the person's name.
Maybe it's better that way. Adapt Pharma Narcan will send a free 2-dose carton of Narcan to any high school or school in the United States. So it's being introduced into schools. And your point about no health professional is needed to give it. And I think if they had a policy, it's within the normal reign of that anybody can do, and also there's no legal liability about getting it. And so the liability of prescribing it for the school district is nil, and somebody giving it, if somebody gives it, there's no liability. So it seems like we should look into that, or somebody should look into it.
Yeah, the reason I bring it up is, we're obviously in the Communication and Public Education Committee, our kids are the ones that are overdosing. And the teachers are the closest to the kids other than the parents. And so it would seem like a natural progression or a natural extension of what we're trying to do is to reach out to the school districts to make sure that every school district, has naloxone on campus.
Good.
Yeah.
And I just thinking, I don't know when to get off topic right now, Counselor, but I'm just thinking that it might be something we might want to agendize at a future meeting, because I think that would be an incredible move for the Board of Pharmacy to take on, and I think it will save lives.
So there was
Bob, will you make sure that gets on our agenda for?
there was
this topic?
There's legislation.
Yeah, there was
Fire
legislation.
departments, police departments, schools, restaurants are all empowered.
There's what?
Yeah, so Business and Professions Code 4119.8 was added a few years ago, and it allows a pharmacy to furnish naloxone to a school district, county office or of education, or a charter school pursuant to, as defined in the education code. So it is existing law that allows a pharmacy to do it, and they can provide it if they have someone that's trained at that location. It does not need to be a healthcare provider.
And someone has to be trained, at the location you said?
It's minimal
Yeah.
training, but yeah.
Yeah. My gut tells me that many university schools, school districts, especially in the underserved districts, probably don't know about this piece of legislation, probably don't know about naloxone and what wonders it's doing to, reverse the people who have overdosed. And it goes back to my point. I think it would be great for this board to take on this task, especially through the Communications and Public Education Committee, to educate, get the word out.
Even through local pharmacists that may want to work with their school districts
Well,
to do
maybe
some
we-
education.
I mean,
Well,
I
maybe
think
we
the
offer
point's taken.
CEs
We
to the
we
local
can figure out.
pharmacists.
I think we can send it back to the committee. They can figure out, do we go to the local pharmacist? Do we try to reach out to the schools, whatever?
And like I said,
And I
maybe we
think
could-
Bob has indicated he will make sure it gets on our future agenda.
Thank you for the time.
Yeah, no, that's a good point. Any other board comments? Any public comment? Good morning, Danny.
Morning, Danny Martinez with CPHA. I wanted to bring up, yes, CPHA is actively providing CE courses for naloxone. We're also aware of the kind of negative stories out there about pharmacists maybe perhaps not wanting to or not furnishing enough naloxone. I wanted to let you guys know that we are working on that, and I think one of the big problems that we're trying to deal with and almost done dealing with right now is that under AB 1114 from 2016, we're trying to get pharmacists reimbursed for under Medi-Cal for providing these services under 493. We're meeting with Department of Healthcare Services in mid-February to finalize this. This has been about a 1.5-year process now, and we're almost there. We're a few yards away from the end zone, and there's been some issues regarding very specific coding requirements. Pharmacists are not recognized at the federal level, as you know, as providers, and DHCS when they're providing reimbursements under Medi-Cal, they have to work with CMS, and so that's been a little bit of a complicating factor. But we think we've figured it out. Like I said, we're meeting very, very soon, and hopefully within the next 2 or 3, perhaps probably around the end of June, is when we expect to have final codes, reimbursement codes for pharmacists so that they can get paid for this. I know personally a lot of pharmacists have contacted us that said, we want to do this and we're ready to do this. We're just kind of waiting for that final step. And I think that's probably one of the barriers that we're seeing is that they're waiting, at least on the Medi-Cal side. We're still trying to see on the commercial side whether they're able to get paid for these services and how often that's happening. We don't have a lot of, or at least I don't have a lot of data on that yet. But on the public side, like I said, we're almost there, and I just wanted this committee to know that.
What is the
Just to
cost of a
clarify-
unit dose?
Let me just clarify. So I think Medi-Cal pays for the drug, as do most insurance companies. It's the
Yeah.
consultation that you're trying to get reimbursed for.
Well, so that's new. So that's extremely, like, within the last couple months. Because prior to that, our conversations were even with the drug wasn't being reimbursed at that point.
Because I think I was thinking that Dr. Gaspar came even like last year and told us it's covered under Medi-Cal's formulary. But the but was that if you're the prescribing or furnishing pharmacist, the rub is, you have to put in your MPI number to process the claim. And so then it gets to, does the payer recognize that MPI number?
And I think that itself has disincentivized a lot of pharmacists to do that. Obviously our folks want to help patients as much as possible. But like I said, we're working on this problem. It should be done hopefully this year, by the middle of this year, and we expect pharmacists to start getting paid for these services, for these clinical services, around the end of June.
And I think the one other barrier with reimbursement is people don't always want to have naloxone associated with their name.
Correct. Yes.
And so then you get that, and that's a barrier.
Yes.
It's going to be a problem.
Yes, that is a barrier. We are encouraging actively, as CPHA, are encouraging our pharmacists to get certified in naloxone and provide the services, start shifting towards a provider services business model for them. That's what we fought for under 493, and we're trying to finish this battle with 1114 under the payment aspect. So, like I said, we're almost there. But I just wanted to mention that we are absolutely encouraging our folks to get involved. And
That's great.
Yeah.
Mr. Lippy?
Okay, two questions. First of all, what is the cost of a unit dose of naloxone?
I actually don't have that information.
Does
So if you
anybody
get
on
the
the board?
injectable, which is harder to administer, it
Right.
tends to be much cheaper, and I'm going to throw out a number of, let's say, about $50.
Yeah, I think
Most
it's 34
people,
is what I
most
thought.
pharmacies, for instance, a chain I'm well acquainted with,
Right.
tends to use the inhaler because it's just so much easier. It's squirt and
Okay,
and
so
that tends to be over 100.
okay, and if somebody walks in and says, I want it, what, is there reporting that goes on? Do you just hand it out as a
Oh, no, you
over-the-counter
still
thing?
process it, you still process it in the pharmacy system as a prescription being dispensed. But if you don't want, if you come in and you want to, get it for your friend, we, by regulation, we do not have to put your name on it. We can put it as John Doe
Or recipient.
or recipient.
Can't bill it that way, though.
Well, so then you can't bill
No,
it.
you-
But,
you have to
billing's
pay
an
for it,
issue
right.
because people sometimes don't want it associated with them anyway, and you can't bill it under somebody else's name, so.
Right.
It's not really cheap right now. It's
So like I just said, it's $50 about for the injectable and well over 100 for the inhaler.
used to be 15. It's really gone
Thank
up.
you.
Supply and demand, capitalism.
Okay, thank you.
Thank you, Danny. Any other public comment? Paige. Good morning, Paige. It's on. I can see the light.
Yeah, thank you.
I can see the light.
Paige Talley with CCAP. In Orange County, I have learned recently that if you have insurance, good insurance, it's $25 for the consultation, which is required, and $30 copay, typically. But
Oh, $55.
but if you don't, it's like for the nasal, 140 to 160. And the
Yeah.
injection is maybe 70
Well, the pharmacist charged $25 for consultation.
in Orange County. Because that's what I don't know personal experience, but that's what I've been told. Yes, on someone who works in Orange County with this.
Thank you.
So the committee does have a recommendation to create a webinar course using the materials presented by Dr. Gaspar to satisfy the educational requirements for pharmacists furnishing naloxone. Can we have a vote to see if the
Will this
board?
be a CE course?
Yes.
Yes.
Okay.
So we'll meet the protocol requirement.
Is this a recommendation, so we don't need a motion, right?
Right.
Correct.
We have to have public comment, though.
What's that?
We'd have to have public comment.
I just did. That's what Danny was
Any additional, now that
Any other public?
now that you've made the motion.
I made the motion before
Already have to-
I even had the board talk.
Any other public comment? Guys, you want to call for the vote? All in favor?
Okay. Moving on to agenda item F, discussion and consideration of UC Berkeley study on the availability of contraception prescribed by pharmacists. So SB 493 also authorized pharmacists to provide hormonal prescriptions. The board adopted that protocol back in April of 2016. The committee received a copy of UC Berkeley's study published in the Journal of American Medical Association in December 2017 that reported only 11% of California pharmacies are currently dispensing hormonal contraception to women without prescriptions. If you'd like to see a copy of that study, it is in attachment 6. The study was based on a survey of pharmacists between February 2017 and April 2017. The study identified several barriers to implementation of the contraception, including pharmacists' concern on training liability, staffing, and lack of reimbursement. So the committee basically, reviewed the information but took no action. Is there any comment by the board?
Well, once again, I'm saddened by that because the lack of interest, it's an opportunity for pharmacists to embrace something good. It's raise them to a higher level for their professionalism. Yet here we are, almost 2 years after the board worked on this, and there's almost no interest at all among the profession. And I have mixed emotions about the different organizations that represent pharmacists, including the one that you represent, Annie, of which I'm a member. But it seems to me that the organizations of pharmacists shouldn't be focused primarily on presenting the pharmacist's view to a governing body such as this one. I mean, I think that they should look over their shoulders and look to advancing what pharmacists are and could be, rather than looking to deal with regulation and legislation for whatever reason that you might do it. And so it's disheartening to me that pharmacists and pharmacy organizations, organizations that represent pharmacists, don't embrace this and don't embrace naloxone, other than maybe to offer a couple of continuing education programs and say, we've done the best that we can. So I'm disappointed, very disappointed, with members of my profession and those organizations that represent them.
I'm wondering, Stan, and I guess I want to ask Debbie, do we know why? Because could it be that there just isn't as great of a market need as needed, that women are going to their OBGYNs or their family practice doctors or nurse practitioners just as easily to get their contraception? I'm just wondering if that's...
We've heard, information that it's very geographical and demographical. And to be honest with you, it tends to be around like campuses or low-income, underserved areas where there's an interest. And a lot of areas, women are more comfortable going to their OBGYN or primary care. I'm familiar with the couple groups that have offered it in a number of different spots. And primarily where they had significant pickup and interest was in pharmacies nearby colleges. And there is right now, as Danny said, it is hard to get reimbursed by the insurance companies, but I do know that pharmacists are asking for reimbursement and people are paying out of pocket, because it is still cheaper than if you have to pay out of pocket and go to a doctor.
So I'm going to ask the same question for this one that I did for naloxone. Can a remote pharmacist do the same thing for these patients?
I see no reason why they could not. They'd have to do a self-assessment questionnaire first. There's a series of steps that the whole process is predicated upon. They could do it remotely, but they'd have to have some means to transfer the self-questionnaire back to the pharmacist. But the pharmacist is required to do any kind of dispensing coming out of that pharmacy, regardless of what the drug is, has to be consulted by the pharmacist.
So if the tech takes a self-assessment, uploads it into the system so the pharmacist can review it, pharmacist can counsel the patient and talk to them over the screen, then that would also be something the remote pharmacy could do.
Because it's still a prescription drug. It does not change the status of the prescription.
And I think, with SB 493, it opens up a lot of things that a pharmacist can do, but not every pharmacist is going to find that providing travel medications in their pharmacy is the right thing to do. Not every pharmacy is going to find providing birth control in their pharmacy is the right thing to do. So I think
there's a market need for it.
That's what I'm saying is the market need. It's different than naloxone. Whereas I think naloxone, I agree with you, Stan, every pharmacist should be able to provide naloxone. I think some of the other things with SB 493, like, hormonal contraceptives, travel meds, that smoking, really even, it's a little bit the demographic, geographic network, the people that you're dealing with, whether there's a need. Because there's a cost and an effort to get up to speed and be good at it, and we don't want people to be not good at it, so we want to be good at it. So you know, I think that yes, probably more pharmacists could be educated on birth control, but it is it's not every pharmacy. Matter of fact, I think it's a smaller percentage of pharmacies that see patients that are interested.
I think it's a chicken and the egg issue. I think that, you know, if there were more interest from pharmacies, then there might be more interest from the public. I mean, if you look at the way things are going with some of the chains, one chain in particular, that they are looking to be thought of as a health center rather than maybe a pharmacy as we go down the road. They are looking to be able to provide health care services, prophylactic and diagnostic. And so this is part of it. And to me, it's just, you know, opportunity missed. I was relating to Ryan, and this is off the track a bit, but when I decided that I wanted to get a
What
condition did your assistant?
what did Stan want to get?
Oh, shingles.
Shingles. When I wanted to get a shingles shot. There's a great joke, but I won't tell. When I wanted to get a shingle shot,
Was it
so I called
shingle
my
or
physician
multiple?
and I said, I want to come and get a shingle shot.
Why
So
would you go to the pharmacy?
he said, you know, you have to get it at your pharmacy, Stan.
Oh.
And so, you know, I had been out of the business long enough to where I didn't even know that the pharmacists were giving shingle shots. But, you know, there it is, a great opportunity of professionalism. And it was available. I mean, he didn't say you can only get it at XYZ pharmacy. He said you got to get it at your pharmacy. Same thing with birth control pills. Same thing with a lot of stuff, smoking cessation. I mean, it's an opportunity that is being missed by the profession, you know, to the detriment of the community. And it's the chicken and the egg. My guess is if more pharmacies did birth control pills, to me, you know, it's the availability is so good. You do
You've
it.
also got religious considerations there that some people, you know, some pharmacies aren't going to do it.
Well, and honestly, if you have I mean, the other thing is there is a cost consideration because if your health plan pays for it and you go to the pharmacy, you're going to be probably paying out of pocket right now. So there could be a cost consideration. So, I mean, you do have to take that in consideration too.
No, that definitely, Stan. It's not just there's no interest, but your hands are tied. I mean, I'm sure the interest in the pharmacists, like, I love to do more business, but almost 95% of the patients have some kind of insurance nowadays. And these are all the benefits that are dictated by the PBMs or the insurance. If they don't pay for it, what can you do? I mean, anything my patients wanted, they have to go back to the OB/GYN doctor.
Any other comments? from the board? Is there any public comment? Danny Martinez.
I understand what you're saying, Stan, and I respect your view. I do want to say that I think your view of CPHA right now in terms of our efforts on oral contraception is a little bit incorrect. We're doing much more than just providing a CE and washing our hands. And this is a little bit tangential, and I apologize if I get off track. Laura will slap me or whatever. The issue Victor raised with the PBMs is a great example of what we're trying to do to get pharmacists focused on providing these services. The dispensing side right now is awful for a lot of our pharmacists. I'm personally traveling to different parts of the state, mostly Southern California, where they have issues with their plans, with the Medi-Cal plans, with PBMs, with you name it, on the dispensing side. And one of the as we're fighting that, one of the remedies that we're personally trying to get pharmacists to do is to provide these services. Now, as has been mentioned up here, payment is an issue, and you know, just like and market forces are also an issue. With naloxone, probably much more of a need out there than oral contraception. I would also say that there are other, in addition to, you know, pharmacists or the OBGYN's office, there's other forces out. Planned Parenthood offers free contraception. They've offered as long as I can remember. So the availability is out there. Now we're trying to get our guys to get in on the action as well. So there definitely is an interest from CPHA, and it does go beyond just regular CE courses. So I want to make sure that the board is aware that we're absolutely trying our hardest. And as I mentioned, I hope that this issue, at least on the public side, is put to bed by the middle of this year, as we finish our work with DHCS. It has been an extremely grueling process. We've had stakeholder meetings. We've had, we've met with DHCS on a number of occasions to deal with this. We've had internal groups figure out what exactly we need to get this moving. We've had outside forces beyond our control put delays in this process. So as I mentioned under naloxone, we're almost there, and we've been trying to keep our guys as educated as possible. We're encouraging them, through our courses, of course, but through any course to get certified in all of these services. Maybe we haven't done as good a job as communicating that effort, and that's something that I'll certainly bring back to my organization as feedback. But I don't want this board to think that CPHA is only interested in just offering CE and washing their hands of the situation. That is certainly not the case. So I'll just leave it at that.
I'm a member of CPHA. I think it's a great organization. Appointments.
I understand, and we're sorry that you are disappointed.
And it's good to hear what you are doing, because the information that I get from all the different organizations that I'm a member of, sometimes it isn't this complete.
And that's something that, again, I can certainly take that back to our organization. If we need to work on our communication efforts in terms of what we're doing, that's a valid criticism, and certainly not the first time I've heard that.
Observation, not a criticism. But thank you, Danny.
Thank you.
Good morning.
President, I'm not going to take very long, but I felt like I had to come up and explain some of the great things that are happening in Idaho, my home state. We just got prescriptive authority to prescribe in 31 different categories of drugs. This goes into effect on July 1st.
Which state is this, Mark?
Idaho. It goes into effect on July 1st. And Stan, I think this is going to create the pharmacy being the health care facility that you're talking about. And in Idaho, we're not, of course, we're worried about reimbursement. But it's the chicken before the egg. You have to prove your worth before people will pay for it. At tomorrow's Board of Pharmacy meeting, there's 3 chains that are showing up and asking for waivers to be able to prescribe right now and not even wait until July 1st. They don't have reimbursement in place. They're eager to get it done. We found it at CVS Health in other states where we're allowed to do strep and flu tests and even birth control prescribing, that a patient will pay a fee if they go to their doctor. It's not free to go to their doctor. If you charge a reasonable fee, 85% of the people that present at the pharmacy will pay that reasonable fee on top of the cost of the drug that you're going to dispense. So anyway, this movement really is happening out there, and it would be great to see it spread.
Thank you. It'd be great to see it. So what is different? So why is it happening in Idaho and different about 2 different states?
Sure, Stan. The biggest difference in Idaho is we're 49th out of 50 states in prescribers per capita. So there aren't enough physicians to deal with the minor ailments that pharmacists are now able to prescribe in. Now, that doesn't mean that there wasn't major resistance by the medical community as these statutes and rules were being passed. There was. But the legislatures, especially from the rural areas, understood the shortage, and that's probably the difference of why we've been able to gain traction.
On a comment on Stan, you got to go to the place where the action is. Regarding the BCP, I know that a lot of high school, the nurse providing all this to the student, readily available for them. So that's where the action is right now.
There's been some discussion actually about having pharmacists involved with Tamiflu, because you need to start this drug like within a couple of days. So getting access to that drug quicker without having to wait to go get a doctor's visit has actually shown some improvement as well.
it seems like a great opportunity. Access of healthcare to the communities that we serve. To reiterate, it's a great opportunity for access to the communities of this state for healthcare.
Is there any other public comment? Okay, seeing none, I'm going to move on to agenda item G, which is discussion and consideration of FDA's proposal to increase consumer protection on high-risk homeopathic drugs. In December 2017, the Food and Drug Administration, otherwise known as the FDA, announced plans to change the way it regulates homeopathic drugs to a new approach based on potential risk to the patient. The FDA said the new policy will focus on enforcement and regulation of homeopathic drugs that pose the greatest risk to patients. The FDA said its regulatory policy for homeopathic drugs has not been updated since 1988. And since then, homeopathic drugs have grown from a very small market to a $3 billion a year industry. Copies of the FDA's news release and their initial guidance is in attachment 7. So during the committee, we noted that there's a lot of homeopathic drugs out in the market today. Some are home remedies used by immigrant communities and imported from other countries. And homeopathic medications are really available in quite a few pharmacies, including not only independents but also some chains. And that we agreed that they need greater monitoring and regulation by the FDA. The executive officer noted that the FDA has begun issuing more recalls on homeopathic products. And the committee noted that since they're carried in a large number of our pharmacies, we are going to start adding those to our subscriber alerts of recalls of these types of products. The committee will continue to monitor the FDA's activities in this area and consider if any board action is needed in the future as it's finalized. Is there any comments from the board members? Any public comment? And we move on to agenda item H, which is FDA's guidance on evaluating the drug effects on the ability to operate a motor vehicle. In April of 2017, the board published Title 16 California Code of Regulations, Section 1744, to require that pharmacists include a written label on a prescription drug container warning the drug may impair a person's ability to operate a vehicle or vessel. The regulation identifies specific classes of drugs that may impair a person's ability to drive a vehicle or vessel. And the regulation also requires a pharmacist to add a written warning to the container of any drug that, based on the pharmacist's professional judgment, may also impair the ability to operate the vehicle or vessel. So that's already a regulation in that's in our books. The committee received a copy of the FDA's guidance evaluating the drug effects on the ability to operate a motor vehicle issued in November 17. The guidance notes the importance of preventing motor vehicle accidents as a result of drug-impaired driving. And the need for drug manufacturers to evaluate the effect on all drugs to that impact. The staff requested the committee consider whether our current regulation in 1744 is comprehensive and if we needed to make any change. And the committee determined that we felt like our current regulation is comprehensive and that there's no need to any amendment or change to our current regulation. And just attachment 8 is the FDA's guidance, if you would like to read it, as well as Regulation 1744. Is there any board comment? Any public comment? I'm going to move on to agenda item I regarding the Journal of American Pharmacists Association article on enhancing the educational value of direct-to-consumer advertising of prescription drugs. So a study was conducted in September-October 2017 issue, or a study was published, I should say, of the Journal of American Pharmacists Association that looked at how well consumers understood and retained information and the benefits and risks of prescription drugs when it was conveyed in a direct-to-consumer advertising campaign by the pharmaceutical company. The study compared the original direct-to-consumer ad with one modified by health literacy, using health literacy principles. The modified ad avoided medical terms and basically used simple plain language, short paragraph sentences, and action verbs. The modified was also printed in at least a 12-point font, and font size this board is very well versed on, with information written at or below the 8th grade reading level. Research found that the participants who viewed the modified ad understood and retained the information about the drug benefits and risks better than those who viewed just the direct-to-consumer ads. The study suggested that risk information presented in the original direct-to-consumer ad was overwhelming for consumers. And if you want to look at the study, it is in attachment 9. The committee agreed that there was a lot of excellent points made in the study, but really, this is quite a bit beyond the committee's scope. The members of the committee noted that pharmaceutical advertising often is used by consumers to pressure doctors to prescribe medications that maybe the consumer doesn't need. But at this point, we feel like this is great information, but not in our scope of the committee or the board. Are there any board comments?
Just a couple interesting points. Only the United States and New Zealand are the only two countries where direct-to-consumer advertisements are allowed.
Really?
And
Just two countries, Howard?
What's that?
Just two countries?
Just two countries in the world,
Really?
yes, and luckily enough, we're one of them. And this has been available only since 1997, and evidently it's very effective because for every $1 spent on direct-to-consumer advertising for drugs, it returns an average of $4.20.
That's a good ROI.
And so I'll bet that's not going away, huh?
Yeah.
Yeah.
I actually remember, this is how old I am, I remember when there were no drug ads, and I remember when direct-to-consumer started. I remember like the big hullabaloo about, you know.
I don't remember that myself.
Well, you're quite a bit younger than I am, aren't you? Is there any public comment? Moving on to agenda item J regarding the Research Advisory Panel of California. The California Health and Safety Code Section 11480 and 11481 require research projects using certain Schedule 1 and 2 controlled substances as their main study drugs to be reviewed and authorized by the Research Advisory Panel of California. The panel includes a member appointed by the Board of Pharmacy, Patrick Finley, PharmD. The advisory panel recently submitted its annual report to the legislature and governor and released it. A copy of the report is in attachment 10. The staff provided a copy of the advisory panel report. The committee reviewed it but took no action. Is there any comment by the board members? Public? Agenda item K is discussion and consideration of granting continuing education credit for reading the script. At the November 2017 board meeting, members discussed the importance of the script, in quotes, that is our publication that the board puts out, as a tool to communicate important information and training for licensees. Several members asked the committee to discuss and consider possible efforts to encourage readership, including the possible awarding of CE credit for reading the newsletter. And as you listen to a lot to the Communication and Education Committee, we use the script as a huge tool in trying to get information out to all the licensees in the state of California. And I think some of the other committees use it also, but it has proved to be a very effective way to communicate with our licensees. The committee agreed that the script articles provide information worthy of CE. It was pointed out that the board currently awards CE for attending board meetings and committee meetings. The committee noted that the board requires 2 hours of CE on law and ethics. I'm getting a little bit to what you're starting to talk about. And it was suggested that reading the newsletter could be applied to meet the requirement by awarding 1 CE unit for each newsletter read, up to a maximum of 2 per the 2-year cycle for 30 hours of CE. Members discussed how to verify reading the newsletter. The executive officer suggested that it would be self-certified like it currently is when you renew your license. You self-certify that I have taken so much CE, and then I guess audit, and upon audit, the person would have to identify exactly which editions of the script they read. Another suggestion was to require pharmacists to pass a quiz included in the script. The committee directed the staff to report back on the feasibility of attaching a quiz to the newsletter that would require participation to answer questions correctly before moving on to the next question. Now, the committee has a motion and a recommendation, so let me read this first, and then we can have discussion by the committee, board, as well as the public, and then we will proceed to a vote. Our recommendation is to direct the Communication and Public Education Committee to pursue CE credit for the script that would apply to the board requirements to earn the 2 hours of law and ethics. So that's our recommendation, because we felt like that was kind of the main information that is provided in the script. Board members, do you have any comments or thoughts?
I think it's a great idea. I think it provides a way for people to really, for pharmacists really to embrace the script, with free CE, and it give us a feeling for feedback, and it give us, and if it's, that it apply to the board requirement to earn 2 hours of CE in law and ethics, with the law portion, we could really emphasize those things that we regard as important to public safety, important to enforcement, and important to that which we want to emphasize as more or less mandatory. And we can be assured of compliance. We have a way to say, no one can be ignorant of the law, or no one can have an excuse of ignorance of the law if it's right there sent out to everybody. So I think it's a great idea, and it can evolve into something even better. Your committee did a fine job on that.
Yeah, I think the script is a place where we could educate a lot of our our licensee, the do's and don'ts. I know. Through all the cases we've been reviewing, a lot of them, they do not do the annual assessment, and I think there's something that a lot of licensee are not aware of it. So I think that's an area that we could educate. We could educate them on the script that, or maybe some of the disciplinary action that you would describe on the script, then they will learn from other people's mistakes so they don't do it themselves. So I think it's a good medium to really educate our licensee. So I really emphasize to educate them. I mean, our main objective is to, public safety. So it doesn't matter which way we educate them. I don't want to have the inspector go out there, gotcha, and get a fine. I more prefer to educate them more so they can follow direction, and that provide better public safety that way.
Hey, Debbie, how do we verify that someone's actually read it?
So that was one of the discussion topics during the meeting, and there's basically 2 ways you can do it. So one is you self-certify. So when which is when we do our license now, we self-certify, yes, I completed my 30 hours. Every so often, there's a certain percent of those that are audited. And so I'm assuming that if we go that route and those are audited, then the pharmacist would have to report, I read, the fall edition of the script 2017, something to that effect. And let me go to option 2, and then Jenny, I know you have some thoughts and you can add to it. And then option 2 is that we literally have some sort of a test. Now, in the minutes, it read that we would have a test you had to answer before you can continue on. Probably more, it's going to be like a 5 or 10 question test on the questions, on information in the script that you have to, pass by 70 or 80%.
And they save the test as the evidence.
That is
And then
something
they would
similar
take-
to the
and then they would
PCA
save the test
classes
as-
that we took.
And then they would save the test as
As
either as
evidence.
evidence or something, but, or there's a way you could potentially electronically do it. We asked the staff to kind of look into this stuff for us. I don't know if you've had a chance to do much with that yet or not, Jenny.
I haven't specifically looked at it, but at the time, one of the things, we've got 2 thoughts here. One of them is they're going to have to interface with the board anyway. We can just keep a record of it and that they did it so that in the event they get audited, they don't go back 9 months later and go, okay, I'm going to get 2 units of CE here and I'll find some more other places, because we want them to be honest about that and not try to find ways around it. We want them to just literally earn the requirement. So I think that we could keep a list of who access. We have their email address, so we know who they are at the front end. So we could do it that way, and that would be simple and straightforward. The one thing, though, I wish to note, which didn't show up in the actual report here, if this becomes a large workload, it potentially could lead to us to having to add staff to address the workload. Right now, we're figuring we can absorb it, but if it's widely available, and we really want to encourage, exactly as Mr. Shad indicated, we really want to encourage our pharmacists to read the newsletter. That's the whole goal of this. So that may just be a byproduct. It wouldn't be an expensive staff person, but we may just be unable to absorb the work.
I have a question on the audit portion of this. So are there guidelines for every pharmacist to keep records so they know?
Yeah.
That already exists.
It already exists.
You know,
Keep them for 4 years.
sometimes we go to a seminar and then they always send an email to us to evaluate the program. So why can't we have something electronically so we don't involve too much staff?
Yeah.
So,
I was just going to suggest what Albert did. Can we just put some self-assessment questions so that if I'm reading it, maybe there's 5 things that we really want them to get out of it. Here's the 5 self-assessment. Even if they don't turn it into us, at least they know what those are.
Yeah, so
At the
focus
back
on
of
the
the
main
list.
thing is electronically, you don't involve too many manpower.
Yeah.
Yeah, we can do that.
And just a couple, in terms, will we give them a certificate so they can only use it for California? So they can't use it for CE for other states?
Well, I don't think we were
correct.
thinking we were going to give them a certificate.
And then could we do a Survey Monkey or something just to ask for feedback on the content of the script? What things can we do to improve it? Just an idea for the committee to look at.
Yeah, we can
I
do
think that's
that.
good.
That's a reader survey.
And I think, and because we look at the script, a lot.
Yeah.
And I actually think it's quite well written.
It's a lot of work.
Yeah.
And then I think and maybe, I don't know, if it's just because, I've been paying attention to it, but I think it's actually kind of been kicked up a notch the last couple of years also, so.
I agree.
And I'm not sure, Bob, if,
Bob gets the credit. Give him the credit.
because
Good job, Bob.
It is a good tool for the board, and so we appreciate it, your efforts.
Thank you. I was just going to add, I spoke to our IT guy, Victor, about possible ways for pharmacists, anyone who reads the script, to self-certify or establish that they have done so. One of the suggestions made at the committee meeting was, is there a way to include 5 questions, I think, that you have to pick the correct answer before you're allowed to move on to the next question. And one of the problems with that is that, if you pick the wrong answer, then you just keep picking the next 3 answers until you get the right one. And so you don't really establish that you've read the article. So that's kind of what SurveyMonkey would allow us to do at very little cost. If we wanted to go to something electronic beyond that, that would require some development and perhaps some more cost. Victor was not aware of anything that we could use, so we'd have to look into that to see what that might entail. Doing a SurveyMonkey to get pharmacists' input on the quality of the script itself, that's something that's very doable. I think it's an excellent idea. I would like to do that very much. But in terms of testing their comprehension and their what they learned, that would be require a little bit more development of something beyond just a simple A, B, C, or D.
But
on
what we
5
could do,
questions.
Bob, maybe like when the script is final, like we have one that's pending to come out. What are like the 5 things that we really want them to get out of the script? So then giving them the self-assessment questions like incorporated in the script so that they know, okay, I've read this, this is what I really should know walking out of here.
Well, I'm actually thinking you just, it's like something they have to print down with the 5 questions. And our instructions are, you need to print and retain this as proof that you completed this. And they answer the questions, and whether they're right or they're wrong, it almost doesn't matter, but they print it, they print it down so they can at least see the 5 things that we want them to get out of it.
So you're suggesting just include something there on what are the important key points of that topic or that article or that issue, whatever, for them to know that this is what we believe is important, to print it out and retain it, but no need to like in some way give us feedback on that they actually read it or.
Yeah, I don't know. I don't personally think they need to retain it, but that you could probably talk about that.
Right.
But I'm just thinking that if I'm a pharmacist reading it, what are the things that the most important for me to glean so that at least I know, okay, this actually, and I think Albert's idea is really good. Those are just self-assessments that I understood the concept.
So it's a one-way communication. We tell the pharmacist, well, this is what's important, but we don't require the pharmacist to tell us that, yes, I learned this or I understand this.
I think what we want to do is, if the board wants us to move forward with this, we don't need to get down the rat hole today. We can have you guys kind of research it, and then we can go down that rat hole at the next committee meeting.
Yes.
Laura, you had something you wanted to add?
Yeah, as part of doing the webinar for the law and ethics, we've been working with the department's SOLID unit. One of the capabilities they have is actually you take the quiz and you can either choose if they have to answer right or not, but then it's submitted electronically to an email address they set up, and that's it. So we would have access to that.
Okay.
The pharmacist could print it if you want it, but it's literally just, it's kind of archived that way. We can look into that to see if it's something we could utilize for this as well.
Okay, that's great. Any other board comment? Any public comment? Art, how are you today?
Why wouldn't the board, whoops. I don't know about the other board pharmacists, but for the last 5 or 6 years, all of my CE is electronically managed by some national organization. So why wouldn't the board just contract with that organization?
Because we would have to pay for ACPE to approve the CE.
Wouldn't that be cheaper than you trying to staff it and trying to manage whether someone did it or didn't do it?
I don't know whether that would be easier. It would be an
Cost
option.
analysis, huh, to see if it's cheaper just to farm it out.
Well, one of the things is that the National Association of Boards of Pharmacy that's used CPE Monitor, which is what that is moving to accept non-ACPE approved lists. It's just that for you to do it, and if you're also licensed in Arizona, Arizona may not accept the credit, the CE credit that the board would give you. And so it would be held outside the system, but you'll be able to report it, and they think that they'll have that done shortly. They're working on that piece now. So you'll be able to record it in CPE Monitor. So for California, then we can access it. We can see exactly how many CE units you took, and that we can see whether or not they were ACPE approved or board approved or whoever approved them. But one of the deterrents initially is that unless you were ACPE approved, you wouldn't go into the system. They're now trying to broaden that a little bit. And it's not just board approved CE. We also accept CE that, for example, the medical board approves for physicians. If it's applicable to a pharmacist and the pharmacist wants to take a particular CME class, we will allow them to do that. Again, that was also outside the system.
I just think, I don't know, is anybody else registered? You must be registered. Yeah,
Yeah,
it's easy. You can go in any time and see where you are.
It's very handy. I actually go in there and I print everything down. I know where I am.
Right, exactly.
Yeah. Hello.
Hi, I'm Katie Antel Rayleigh. I just have a question regarding.
You might want to put your mouth a little bit closer to the mic.
Oh, I'm sorry. Katie Antel with Rayleigh. One of my questions was, since we're registering everybody's email now on our on the part where we have the licensing information, you bring up the person's name, is got their license and all that information. Why don't we have just like a little box in there that says that, yes, you have received their email address, since we have to have it on file anyway without posting it. But then when we do a test on the script, we just go ahead and on the script, it just says, have you questions? You say yes, and it automatically populates onto our license that, yes, we did go ahead and reread the script. And
We can
So
take a
then we're
look
not
at that as an
I'm sorry?
option. Yeah, I'm not sure how we would do that because the system isn't quite set up like that. The other thing is that a lot of the email addresses per se are not really linked with your license number. So you could be anything at some other address and we would never think it was yours.
Oh, I see. So it wouldn't identify.
I think they're going to look at the mechanics of the licensing committee.
And then
Communication Public
Yeah,
Ed.
but thank you. No, we hadn't thought to look in that direction, so.
Okay, thanks.
Thank you for your comment. Is there any other public comment? So we have a committee recommendation. I'll read it again. It was direct the Communication Public Education Committee to pursue awarding CE credit for the reading of the script that would apply to the board requirement to earn 2 hours of CE in law and ethics.
All in favor? All in favor, raise your hand.
Thank you. Just a last couple of things. The staff updated the committee on the many news, media, and public outreach activities that they are participating in. It's quite extensive, quite impressive. We really appreciate your efforts and all that you guys do, both in the public outreach and all the presentations you do, and the support, you support your staff to do it too.
Hear that.
Yeah. Yes, and we appreciate all of your outreach with the news media, getting the word out there and the updates that we received. But if you'd like to read through them all, it's quite impressive. You can go to attachment 11. I'm not going to do that. Future committee meeting dates are currently scheduled as April 25th, July 11th, and October 11th. Is there any board comment on the last two agenda items?
Debbie, I wanted to congratulate you and Ricardo because this is a really good report. I've seen the Communication and Public Ed Committee really step up, and the content of this today was very proactive and very focused on educating the consumers. So and our licensees. So congratulations and thank you.
Yeah, I mean, I hope we reflect that in the minutes because I think Ricardo's done an outstanding job being our chair.
Thank you.
I would just like to give a shout out for Victor. Good guy, does a great job for the pharmacy board. And I just.
Bob, that's Bob.
No, but you're working with Victor, right?
Yeah, he's
Victor's a great guy. I second
Yeah,
that.
and so I just, I'm sure that, I think we have said that the job that you're doing is good, but
So Victor, if
Victor's
you're
not here.
watching,
And I just
Victor,
want
if you're
to,
watching, which you may
yeah,
be
Victor,
doing,
if you're watching, thank you.
Bring down the computer system fast and then bring it back up. Thank you, Stan. Thank you for commanding them.
So let's take a 10-minute break.
And let me just say, is there any public comment on the last two items? Okay, now I turn it over to you, Mr. President.
Thank you, Chairperson Veal. So let's take a 10-minute break and come back here at 11 o'clock, and we'll have enforcement and compounding.